Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
our topic today is oncoplastics.
how was Japan?
Japan was awesome. I got back from Japan.
I saw 2 celebrity sightings on my trip. I
have made a horrible mistake. I have misrepresented my cow. It's actually not.
Oncoplastics is new, but not new. And it means something different too.
Something that's super important that we have to all agree on is that we got to take...
Is it always about making them look like they did, or is it sometimes...
I like to kind of divide the patients that I talk to oncoplastics into 2 groups. They're sort of...
Is oncoplastics the correct term? In hospital after hospital, they are not giving the breast surgical...
For instance, in our area, our plastic surgeons are like, you want to get into that? Here.
Should it be offered to every patient undergoing breast surgery?
She deserves to look good.
Does she deserve a discussion about the options? Why?
Yeah, This is Carla.
Ellie.
Michael.
Susie.
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Our topic today is oncoplastics. But before we get started, let's begin with some personal and professional updates as usual. Carla, what's new with you? How's the reconstruction going? Actually, it's a renovation, isn't it? Let's
This is our
again.
world. No, this is our world. This is our world. That's what we're used to talking about. Yeah, I probably used the same term. So the renovation, we have an estimated end date of end of July, mid-August. So
Of 2025 or 2026?
Yes, 2025. So the original 3 to 4 months is at about 5 months. I anticipated it would be 6 months. So we're getting into the summer months. I think it's easier to be driving in your car and living at the lake rather than in March when we started. So no complaints from me.
How was Japan?
Japan was awesome. I got back from Japan, as you guys can imagine and anticipate, and as some of you well know, it's an amazing place to visit. The food is wonderful. The people are wonderful. I was with my brother and his kids, and we took public transportation everywhere. I will tell you, I don't know how any of us ever traveled overseas without Google Maps, but it just gets you everywhere. So highly recommend a Japan trip to all of you who are listening.
So, Carla, having grown up there and spending years with your brother there, was it emotional at all being back there?
Oh, absolutely. We went back to the town that we lived in. We went to Kobe, and we actually FaceTimed with my parents when we went to the apartment building that we lived in that my brother tried to jump out of the 6th floor when he was a little 3-year-old, not on purpose. He was caught just kind of standing in a window trying to have fun. And we actually did a recreation. You know how people do those old photos? Yeah. So we have a photo of us sitting on the front steps with my mom, and we recreated it. I look only a couple years older, as you can imagine. Very like people.
You didn't recreate him trying to jump out of the 6th floor window.
No, but we did look up at it and think we didn't quite get in. But actually, no, we went back to the school that we went to as well. And now I'm on their alumni email list. We went to St. Michael's in Kobe. So yes, it was a wonderful trip, spent time with family, ate well, and had a lot of good memories.
Do you speak Japanese?
Konnichiwa, sayonara,
Okay.
mushi mushi, hi. We knew a couple words, but I was a late bloomer, as they like to say. Yeah.
Me too. I did kindergarten twice, so that's okay.
Oh, there we go.
You're in good company.
Ellie, what about you?
I recently traveled back to Kansas City for graduation season. That's where I grew up, so I got to see family there. I saw 2 celebrity sightings on my trip, which was shocking. I saw Derek Huff, the Dancing with the Stars guy. And then I saw, well, I don't know if this is a celebrity, but I saw a Real Housewife. So it
Which one?
Oh, she's from Real Housewives of Orange County. Her name's Gina. I can't even tell you her last name, but she's from like the first season. But yeah, it was a great trip. Good to be home. Michael, what about you? What's going on with you?
I was at Benihana the other night, so I really kind of feel what Carla was like. I mean, I almost as if I was in Japan. I have made a horrible mistake. I have misrepresented my cow. It's actually not a bull. It's a heifer, which is a female bull. I think I mistook the umbilical cord for other things. So the naming process is going to have to take a little bit of a shift. That's a big problem. So
But Bovie can be anything.
Bobby's fine, but
can be anything.
like Susan would be a problem.
Susan would be.
No, Susan wouldn't be.
Susan would be
I
fine.
think we should use Susan. Speaking of Susan, Susie, tell us what's up.
Well, I did my 3-year running streak, still going at it. Over the winter, I had a couple that were pretty cold. Then I was really excited now that it's been warming up. It's been really nice. All right, Susan, tell me what's going on in your neck of the woods.
Oh, well, in my neck of the woods in Connecticut, it's starting to warm up, which is a fabulous thing. Kids are home from college, which is the best thing ever. It's so much fun having a house full again with all their friends here every night. And it's graduation season. So 2 of my nieces are graduating in the next few weeks, one from 8th grade and one from college. So nice, fun family events. So let's get into our topic today. And as I said, it's really about oncoplastics. Oncoplastics is new, but not new. And it means something different to everyone out there. So, Susie, let's start with you as a general surgeon and that viewpoint who has a large practice in breast. But what does oncoplastics mean to you?
Something that's super important that we have to all agree on is that we got to take care of the cancer first, onco. And then I think we need to be able to make people really look good and be proud of themselves. Now, this can be done with a wide range of things on there. It does not have to be super complex, but sometimes we do need those complexities and people who have had different training to achieve that. So I'm a pretty keep it simple kind of gal. Get rid of the cancer, look good, be proud of yourself. Ellie, what's your expertise on this? You're the person who knows so much about this.
That's a great description of it, Susie. And that's what I tell patients. I say it is first and foremost a safe cancer surgery. But the second part, the plastic part, is making you look similar to what you looked like before the surgery. And that's the ultimate goal. We're not so lucky all the time that we get to do that. But a lot of the time with these techniques, you can do that and you can make the patient look very similar to what they're used to looking like. And I find patients can really kind of connect to that description of it. It does take a lot of work, a lot of coordination, and a lot of planning from a surgical standpoint. So it's a very intricate thing that does take effort on the surgeon's part. So I think having buy-in from multiple people, having your radiologist on board, having a way to communicate to your team, especially radiologists, if they're placing your guide wires or localization seeds, that part is super, super crucial to be successful in oncoplastic surgery.
Carla, is it always about making them look like they did, or is it sometimes making it better, doing a reduction? There's so many things involved potentially in oncoplastics. What's your thought on this?
I'm glad you asked me because I was actually thinking about that. I think you're right, Elliot. The hope is that we get them to look as similar as possible, but I'm sure all of us have had patients who actually are much happier with their breasts after an oncoplastic surgery. And so I like to kind of divide the patients that I talk to oncoplastics into 2 groups. There's patients who have very large breasts or very ptotic breasts. It happens to all of us with time, and the nipples start to face down towards the ground a little bit more. And so you have patients with really significant ptosis. They can have large or small tumors. That's kind of the one group. And then you've got the other group where maybe their breasts are a moderate size, but maybe they have a really large tumor or multifocal tumor, and they're really hoping to preserve their breast. And we can maybe talk a little bit about extreme oncoplasty, because this goes the whole gamut. And so you've got those two groups of patients, some of who, if they're going to have a lumpectomy, have to have, I think, an oncoplastic procedure. And then the other group where maybe you could do a lumpectomy, but with their large breasts, with the ptosis, which they're fatty breasts, and radiation afterwards, probably are not going to have the best cosmetic result with a lumpectomy. And so those patients in that first category, kind of back to your question, Susan, they are so much happier with how their breasts look and feel after an oncoplastic procedure because they've had a breast reduction. We've removed the cancer. I've been able to be a little bit more generous in terms of the tissue that I've removed. And I think a lot of those patients do better with radiation. I think the radiation planning techniques can be better for them. So I think oncoplastics is such a wide variety, but it really can give patients a wide variety of outcomes from a cosmetic standpoint as well.
There's no definition. It's sort of
That's my point.
The definition in everybody's head is kind of weird. We were setting up new curricula for the fellows, and we knew that it was going to be important for them to have oncoplastics. So we've required it. You have to have hands-on oncoplastics. Nobody could define it. What are we requiring? Is it a hidden scar? Well, we don't think that's it. Is it an implant? Well, no, maybe that's too far. Is it a breast lift on both sides? Is it always bilateral surgery? There's really no definition that we can work off of. It's sort of in the eye of the beholder as to what they think it is. It's strange.
Let's think about it in another way. Is oncoplastics the correct term? If we can't even define what it is it the correct term? Does it mean a plastic surgeon needs to be involved? Do plastic surgeons own oncoplastics? Breast surgical oncologists, can they play a role in that? Carla, what are your thoughts on that?
Historically, we went from mastectomies or even radical mastectomies for all patients with breast cancer to mastectomies. And then we know that BCS or breast conserving surgery was safe for patients as well. But the goal when this was first started was to remove the cancer and preserve the breast. But there was not really a thought process in terms of how it looked. Oftentimes, these were quadrantectomies where a quarter of the breast was removed and sort of left in place and the patient got radiation. At that time, that was an improvement. And so I think the transition to oncoplastics, and I think Susie started it out, get the cancer out, plastics make it look good. I would argue that I think when you talk about hidden scar, that's a first step in oncoplastics. And we have started to try to define this field. And Ellie, I think you've had probably the most, if not the only kind of formal training in this, but we talk about level 1 and level 2 oncoplastics. How do you think about those things a little bit more?
I disagree a little bit with you, Michael. Like there is a definition for it. There's level 1, 2, and 3. Level 1 is you've done a less than 20% volume displacement, and that's usually local tissue rearrangement that you're doing. Level 2 is where you're doing 20 to 50%, and that's usually where reductions fall in, or nipple displacement or minimoplasty. Also like a local transposition flap is included there. And then volume 3 is transposition flaps or implants or anything like that. So you can categorize it in that way. That's really how we define it formally in our oncoplastic training, is keeping it in those levels.
That's not accepted worldwide. We had an international meeting and spent 4 hours or so discussing this, and no one could agree on the levels and what it meant. And not everyone agreed that, level 1, it should be even called level 1, 2, and 3. Because internationally, that's not how it's always referred to. So I do think that there's a major problem with definitions in oncoplastics, which is why when I teach it, I start out by saying it's a mindset. You have to start thinking about oncoplastics and how you're going to get this breast to the end goal of maintaining the shape and contour of the breast. How do we do that? That starts when you meet the patient, or even before that when you're looking at their imaging. So it really is a mindset, but I don't think that internationally there's an agreement upon levels or that it should even be called levels.
From my perspective, I'm super excited that there's people who want to go to 4-hour meetings to go to these consensus. So like you go for that and then give me the punchlines. And that makes me really, really happy. But for me, when I approach a patient, it's shocking. Like if you have a 5-pound bag of rice and you take out a cup, I mean, you're still like trying to get that zipper shut. And I think breast tissue is pretty darn amazing how if you plan an incision, it can really fold in and you have to be thoughtful and you don't have to make every case super fancy. And I think that's beautiful. And when we meet the patients, figuring out what their goals are, this is sometimes an opportunity for people to say like, man, this cancer, this is awful. And being able to have that conversation. And for me, I don't do level 3, but I have some awesome plastic surgeon colleagues and being able to work with them and say, hey, these are the goals. I think it's super important how we work together with that.
Now, I want to go back to your original question because you said, did we misname it? And I think we unfortunately named it Oncoplastics. I wish we would have named it aesthetic breast closure or something like that. Once you threw the name plastics in there, it became something a little bit that the plastic surgeons had say to some degree as to whether you have privileges in or can you actually do this. And we've had to develop workarounds for that to some degree to even get privileges for that. Yes, we do use techniques that are traditionally in the plastic surgery space, but it did create a barrier for us in just doing the right thing and making it look good. I don't know if it's too late that the genie's already out of the bottle and you can't change it to something else. That was an unfortunate first step in misnaming.
I love it because with plastics is like rise to the occasion and show that you have some of these extra tools and extra things. I feel like that's...
No. I'm not talking about what you sell to the patient or what you talk to the patient about. I'm talking about you want to do this in your OR. And now there's a different hurdle that you may have to jump through. And that's what I'm talking about.
Aesthetic flat closure, that's terrible because aesthetics is like in the eye of whom? That's really hard with
Susie, it sounds like in your hospital, it's not an issue, but I can tell you in many, many of our members' hospitals, they are restricting their privileges. So they won't give them privileges for oncoplastic reductions, which many breast surgical oncologists can do their own oncoplastic reductions. In hospital after hospital, they are not giving the breast surgical oncologist privileges because frequently the chair of plastics gives privileges for plastic surgery procedures, and that's listed as a plastic surgery procedure. So it is a problem that our members are having. So that's why this topic came up. Now, I'll give credit to Dr. Rhonda Henry Tillman, who believes it should be called oncosurgery. Is that correct, Michael?
I was trying to think of what
think
she
it's
had
oncosurgery.
It's something to that degree.
I think that's what it is. And that really does describe more of what we're doing. Because if we do call it oncoplastics, it falls under a plastic surgery realm by definition of the name. A name is really important, but as someone said, that genie's out of the bag. And the question is, how do we go around it? If someone puts an obstacle in our way and we think it's in the best interest of the patient, we still have to get it done. We just have to figure another way around it to get that done.
Who is doing this stuff? And one of the things is we all come from very different practices. And I have been involved in training, as have many of you. There's sort of the range of oncoplastic as my primary. This is what I do. This is a big part of my practice. It's a tool in my toolkit. I think there's very few breast surgeons who don't do it at all. So we have different people listening. We have learners and residents. Depending on the type of place that you practice is going to affect this a little bit as well. Because we have a lot of our membership who practice in places where they don't have access to plastic surgeons. And I'm not saying you need to practice oncoplastics just in those areas, but obviously that skill set is incredibly important to them. I am in a department where I have absolutely amazing plastic surgeons. They work with me through so much, and we do all sorts of stuff because we've got my skill set and knowledge and their skill set and knowledge, and it works out really well. And so I think for people that are thinking about this and interested, having that mindset is really important up front, and every breast surgeon should have that. How much you practice that is going to depend on the type of place that you're going to be practicing, both by academic or community, Indiana or California or Washington, what kind of hospital you're at. We're kind of talking about the privileges. And so I think as people start to talk about this, it can sound really sexy, but you want to make sure that you're in the right practice environment for the extent of surgery that you're going to be doing.
Carla, would you have pushback from your plastic surgery department if you said, you know what, I got this. I've been practicing this and I'm going to go ahead and do a big volume tissue rearrangement, and then I'm going to go to the other breast and do a symmetry surgery. Now, I know you've got great plastic support, so do I, but let's just say you just decided that this is what I'm going to do. Would you have pushback from the plastic surgery department?
It's hard to answer that. I would say yes and no. I mean, I have a really good relationship. I think part of being in academics is being a good politician. So those who've been successful tend to be good at that. I'd go back to, what about doing core biopsies? I know you probably do core biopsies in your practice and private practice.
Yeah.
That is not something, and we struggle with that a little bit with training, but our radiologists do that because I'm in an academic center and everybody who practices in academia is in the same position. Our radiologists do that. So I would say it's relatively similar, but I have trained people who are in moderate size academic institutions where they're able to do oncoplastics. And I think it's just a balance of your timing and your relationships. We have a big academic center with different community hospitals. Depending on where we were doing those procedures, they'd be okay with it because I have a good relationship with them.
I completely agree, Carla. It's about those relationships. For instance, in our area, our plastic surgeons are like, you want to get into that? Here. We are going to help demonstrate, because your credentialing is about demonstrating that competency. It's not going to a weekend course. But back to Susan's point, I think it's really great that we all have this framework. What is it? Even if you're not doing level 1, 2, 3, whatever it is, that you understand, if you have a board certified plastic surgeon that's coming in after you, what are they doing? And I think it's a really important conversation that you can have surgeon to surgeon, and also that we're able to communicate some of the basics to our patients and know what options are out there and when certain things would be available or totally off the table. It's important to have that knowledge whether or not you're practicing it.
Without a doubt. And that goes for so many things that we do. We don't deliver radiation, but yet we have to know about it and we have to be able to explain it to the patient. We have to be able to explain the options of oncoplastic surgery, mastectomy, and reconstruction. That is in our wheelhouse. We may not be doing it all, but we absolutely need to understand it, know the options, know how to discuss it and explain that to the patient. But several years ago at one of the American Society of Breast Surgeons annual meeting, there was a debate. We always have lots of debates at the meeting. There was a debate whether or not every patient deserves, that's a bad word, but it's what I'm recalling, oncoplastic procedure. And what are the thoughts? Should it be offered to every patient undergoing breast surgery? Ellie, what are your thoughts on that? I can see the wheels turning in your head right now.
I try to offer oncoplastic surgery to everyone that I can, but if there is a surgical patient who has a lot of medical comorbidities, who has an extremely fatty breast where tunneling is going to be a disaster, if it's that patient that I just want to get in and off of the operating table as fast as possible, no, I'm not going to offer them oncoplastics. That is not the right patient for this. This is for a healthy, non-diabetic patient that can get in and out of the operating room.
So doesn't it depend on what your definition is? So if your definition is a mindset to have the breast maintaining the shape and the contour of the breast, doesn't every patient deserve that? Just what you said, it's making the breast look similar. It's where the scar is, it's a tissue, it's a small tissue rearrangement.
If you've got an upper outer quadrant 1 centimeter cancer in someone with very pendulous breast or whatever, very large breast, and you go and you take that out and maybe use an axillary incision or something to get there. No, I don't think you even need to put them through what it would take to give them a lift and symmetry surgery. You can sneak that out. Aesthetically, it looks fine. Does she deserve it? She deserves to look good.
Does she deserve a discussion about the options if she wants?
You know, I think sometimes you're trying to pigeonhole a patient into a surgery. I think that if they can be best served by a small incision and take out a small lump and move on. Yeah.
What happened to shared decision making? It doesn't sound like you practice that way.
No, I tell everybody what they're going to get, and I meet them in the OR the next day. I mean,
I'm a little
what you do? What are you talking about?
I'm on board with you, Michael, and I love your comment, Ellie, about tunneling, right? And as a fellowship director, I think sometimes the hidden scar technique and the periareolar incision seems so necessary that people will tunnel 10 centimeters to get a cancer where they can make a 1 centimeter incision. Sometimes that tunneling comes back to bite you in terms of the cosmesis when you start doing radiation or they're healing or they get a giant seroma. And so I think that we definitely have to think through that. But I agree with you, Michael. I don't necessarily give that patient an option if I think it can be done through an easy incision there. I will say anybody who's got a large amount of ptosis who doesn't have some of those medical issues where I think offering them a bigger, longer surgery, I will talk with them about it. But one of the things I usually say is I can do a partial mastectomy in an hour, and this oncoplastic procedure is going to be about 3 to 4 hours, and your recovery is going to be significantly different. And I have patients who are like, oh yeah, no, I don't want that long recovery. Again, that's the shared decision making and what the priorities are for them. I have some patients who go, I didn't even know that was an option. I'm sure you guys have all had those conversations.
I completely agree, Carla, and I hate the idea of do they deserve this? I think everyone should
I started
have.
saying it was a bad word, but
I
that was,
know.
well, I remember that debate. I even remember who gave the debate.
Are they obligated
It's
to
like-
hear that
it's-
conversation?
Right, and I
Do they
think-
deserve the discussion? Is it shared decision making offering the options?
I think it's a discussion, and I think, Carla, what you said is exactly right, because I have seen a few patients who've had surgery elsewhere who said, I just said I want it right over here. I don't care if I see a scar, and even if it was like in a V-neck or whatever, that they don't care. And if you have something that happens after a bigger surgery, you have to be able to look at your surgeon in the eye and be able to say, you know what, we went through this together and we tried for this, because complications are going to happen to every surgeon. And we certainly hope they never happen. And we want to do the best job that we can at all times, but sometimes things don't go exactly as planned. And we have to be able to have that discussion on the backside that if an incision or if there was tunneling or something happened after radiation or something, that we're able to say, yes, we see this, we're moving on. We had this discussion ahead of time, but they weren't forced into this big operation that they didn't actually want.
I think you're going to the extreme of forcing someone in. Offering someone options and forcing them in are two different
Agreed.
things, without a doubt. But at least in my experience, and I'm not quite as old as Michael, even though, I don't know.
At least a decade, right? I mean,
Very,
Michael's pretty old, right?
He's
very close. Months.
But the whole thing is, countless patients say, I don't care how it looks, I just want the cancer out. Now, we know they mean that with every ounce of their being at that moment.
Right.
But 3 years when they're doing great, 5 years when they're doing great, a decade when they're doing great, and their breast looks terrible, they care. And it reminds them of breast cancer every day. And that is one of the amazing things about oncoplastic surgery is they don't think about it because their breasts look great. So how do we combat that and balance those two things with that patient saying, I just want the cancer out. I don't care where you put the scar. We know it matters in the long run.
I agree, because I think there's one thing where you can look good under a swimsuit, you can look good under a bra, but you do want to look good naked too. And I think that's important to have that short term as well as the long term. And I love what Carla said, like, yep, and here's the differences between there, and giving them those options.
I think this is a really good opportunity, and there's a lot of companies looking at how we can predict cosmetic outcomes. And there's actually research I'm getting involved with, but I know there's other groups who are looking at this with the imaging technology that we have, looking at breast density, size of the breast, location of the cancer, size of the cancer, being able to predict what that outcome is going to look like. And so I think I would just say stay tuned, because I think we're going to have tools that will help us as surgeons be able to predict, and not only help us, but help our patients. We've seen those plastic surgery shows where it's like, here's what you look like, and here's what you're going to look like with this new nose. Wouldn't it be cool if we said, here's what I'm predicting you're going to look like after you have lumpectomy and radiation?
Stay tuned. I don't
Dun,
think
dun,
it's that
dun.
far
Cool.
down the road.
Yeah.
We're nearing the end of our time. What are your takeaways? Ellie, let's start with you.
Well, I'm shocked to find out that the definition is not universal.
She's still reeling from that a little bit.
Just like speechless over there. Ellie, that was 30 minutes ago.
blew my mind. Yeah, who knew?
Okay, Carla?
This is less of a takeaway and more to our listeners and people who are interested in being in this field. I think the point about where you're going to be practicing and what you can do, I think it's a great skill to have. And I think I would look into different training programs in terms of what they have and think about what your future practice is going to look like.
Susie?
I just love keeping it simple. Get rid of cancer and look good. And having that conversation of there's a huge range of what can be done, what people want, and what those recoveries are. And being able to have that shared decision making without going off a cliff when it's not appropriate.
I like it. I like it. Michael, we know that you really are a fan of shared decision making and believe strongly
Don't even know what that
in that. So what's your takeaway?
Patients deserve to look good, and you need to have the skill set to make that happen. You need to know these techniques that can allow for that, so you're not leaving a big cavity in the breast. The seroma is not your friend. You need to be able to close that. You need to be able to offer some of these techniques. Not everybody's going to be as good as Ellie is at this, but there's some really simple techniques that you can do if you understand the tissue planes and those little maneuvers that you can do that will just make them look better while you're there. And it doesn't take 8 years of training to learn those things.
These are all incredibly important points, and it's also know your limits. Maybe we know the procedure that we want the patient to have. We need help doing it, and that's why we work in a team. Taking care of breast patients is a team sport. It's certainly not an individual sport, and we need our plastic surgery colleagues. We need our radiology colleagues, and certainly involve the entire team in something like this. But this has been a fabulous discussion. As Michael has stated to me before, I'm not sure that we actually answer any questions. We just continue to bring up more and more points, but we could discuss these topics for hours and hours, and everyone approaches it with a different viewpoint. So I think it's great. But all good things must come to an end. So to our listeners throughout the entire breast community, we're so excited that once again you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie.
Michael.
Susie.
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.